Welcome to the Dr. Lexi Show, where I take pregnancy topics and help to put them into simple terms to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal-fetal medicine specialist, which just means a high-risk pregnancy doctor. And today on the podcast, I have a very special guest, and I cannot wait to talk to her more and for you guys to learn so much from her. Lisa Miller.
Hey, thank you so much for having me. I'm excited to be here.
Right. I'm going to give you some of my questions that I ask all my guests.
All right.
Just for fun. There are 10 questions, and then right after that, there's 10 quick true or falses. And so we'll just roll through them.
Okay.
Sometimes we get on fun tangents, and that's totally fine because that's the point of it all. All right. Question number 1. What does the abbreviation OBGYN stand for?
Obstetrician and gynecologist.
Wondermiss. Question number 2. What do the letters MFM stand for?
Maternal-Fetal Medicine.
Yes. And you know, so many people, especially like that know me and know what I do, get that wrong.
You're kidding.
No. Oh. It's like a tough one. And also I always tell people that, they call it perinatologist as well. And that most people hear paleontologist.
Oh, paleontologist.
Yeah. I'm
That's
like,
nice.
That's cool.
Maybe it should mean many fun moments.
Yes. Ooh, I like that.
Because when we're together, that's what we have.
We do. So. We do. And just the labor floor is just full of those fun moments all the time.
Also true, stranger than fiction.
Yes, very true. All right, question number 3. How does a provider come up with the due date for a patient during pregnancy?
Well, it's calculated. It's called the estimated date of confinement, which is such a strange term to me for delivery. Calculated based on your last menstrual period. Mm-hmm. But because that can be irregular in people, most people in the United States today are often getting an early ultrasound to help gauge the due date, correlate it with the last menstrual period calculation, and then adjust things. Mm-hmm. So accurate dating through the use of early ultrasound, I think has really improved outcomes. I don't know, you would know more about it than I as an MFM, but I do believe that's made a huge difference in the healthcare of women and babies.
I think it has, and you'd be surprised, and you would think because we have such great technology with the ultrasound machines now, that people would be getting the ultrasounds early enough and we would get these due dates earlier in the gestation. Right. So many times I'm doing an anatomy scan or reading an anatomy scan at 20 weeks. The due date has not yet been established.
And no prior scan?
No. And this can be due to multiple things. Patient didn't know they were pregnant. Provider didn't place the order for the ultrasound. Patient missed the appointment, couldn't get rescheduled. OB provider had someone in their office do a scan with a quick something, didn't document it anywhere, and they said, oh, this was the due date based on a scan that no one can see. So this is why one of my big things, I have a download for this, is like, what is my due date? Because then you as the patient can print it off and you can compare all the info, like if my last menstrual period was this, and my ultrasound says this, should they change my due date or not?
Right.
Because we have to look at those charts all the time. Right. I mean, it's,
and that's an important discussion to have. Also, to make sure people understand, I think, that the due date is not an exact date. Mm-hmm. That in fact, in my experience, most first-time moms will go over the due date, and that was not uncommon. Yep. But it helps you kind of make a plan.
Yep, and it is an estimated due date.
Estimated date of confinement.
Yes, just like an estimated fetal weight, right? Estimation.
Right.
It is an estimation. It's not perfect.
That's right.
All right, question number 4. When is a delivery considered preterm?
Well, you have now new designations for that, so that there's, I can't remember what they are, but prior to 35 to 36 weeks. So there's near term, preterm, and these are all designated, but I'm going to fail this quiz question to get them exact.
They made all those definitions for anything after term. Right. So at 37 weeks and beyond, and then basically anything prior to 37 weeks would be preterm.
Right, but there's preterm and then there's preterm, because
there's early preterm and then
exactly,
and they subcategorize it all.
I always have to look those up.
The reason I like that question is because, like, when patients are talking to their providers and they're like, "Oh, is your baby born prematurely?" Well, what do you like? Can you tell me what premature is? We can't, as providers, assume that a patient is going to know all those definitions when they keep changing them on us anyway.
Well, exactly. You know what I'm saying? How many weeks? They might know their due date and the date the baby was born.
Right.
But you're going to have to extrapolate.
Exactly. Or the months. Like sometimes they're like, oh, I was
9
6
months or 8 months or 6 months. Right.
Yep. Question number 5. What is the normal fetal heart rate?
The normal range for a fetal heart rate is between 110 to 160 beats per minute. And this rate usually is faster earlier in the pregnancy and slows down as something called the parasympathetic system, which is a nervous part of the nervous system, develops. So it would be slower at, say, term, near your due date, and faster early. But anywhere within that range is considered normal.
Because you're literally like an expert in this field, I'm going to ask you a separate question. Okay?
I'm ready.
So I struggle with this when I'm reading ultrasounds and a sonographer doesn't point out to me that a heart rate is 170. They're like, oh, it's okay. It's 20. This kiddo's 25 weeks. That's fine.
No.
So when we say that range of 110 to 160, when we have an embryo, it's very small, or we have, let's say, even like a 9-week fetus. They've kind of changed these definitions now, like saying if we're below 8 weeks, we want to say embryo. If we're above, we want to say fetus.
Oh, I did not know that.
That's a new one. Yeah.
New to me.
I know. So whether we're saying, but let's say we're 9 weeks along. So we're little peanuts. That heart rate could definitely be 170. I'm okay with that. My question to you, because people are splitting hairs with this, right? And so at what gestational age can we go ahead and say the 110 to 160 sticks? You see what I'm saying?
Yeah, and that's a great question. I would generally say 24 weeks and beyond. And then there may be a gray area between 20 and 24 weeks.
I agree exactly
But I don't think we can give a normal rate for under 20 weeks gestation. The systems that control the heart rate just aren't developed enough yet.
Yeah. I mean, if it's above 200 or if
well,
it's...
yes, obviously. Then you have maybe some type of arrhythmia
Yes.
or things like that.
Yes, okay.
So,
Thank you.
But I wouldn't use strict parameters prior to about 24 weeks. And really prior to 24 weeks.
I agree.
I think it could widely vary.
And because I have sat through your course before and enjoyed it, when we say 110 to 160, inform me very specifically, are we within that? Are we equal to 160 or 159? Do you see what I mean? Like,
it's 110, includes 110, includes 160. So fast heart rate, which we call tachycardia, would be 161 or above. And a slow heart rate, which we call in the business bradycardia, would be 109, 108, anything below 110.
Thank you. It's
course.
funny how those specifics can really come into play.
No, same thing
Right?
with like diabetes testing. What's the cutoff? What if you're within 1 point?
I know. The numbers, the math. I hate math, by the way. I don't know if I've told you this before. But
I was good at math,
Were you?
but I
was
can't say
not.
I enjoy it.
Okay. I was really bad at math. Actually, I was good at math. I just don't enjoy it because now I just count on my fingers or use
nobody
calculators.
can make change anymore. Let's face facts. I can't make change.
No, I can't either. Let's see. Okay. Question number 6. At how many weeks during a pregnancy should the anatomy ultrasound be done to look at all the parts of a baby?
That is something I would ask my MFM. But I'm going to take a guess because I am not a high risk.
No.
I'm a nurse midwife. I would say between 18 and 20 weeks.
Spot on. Absolutely. That's right. And I like people, like if you think about 40 weeks is considered when you're like, that's when your estimated due date is, you're like 40 weeks. So when we say like, when's your due date? That's the day you're 40 weeks. Think about it halfway, right? That's a good way to think about it. I like that. Question number 7. How does an ultrasound estimate the weight of a fetus?
Oh my gosh. You know what? I'm not sure I know, but I think it is based on data that was obtained when I started in nursing. Dr. Rudy Sabaga was one of the people working on this, and they were taking measurements of the femur length and other anatomical structures, and then they were getting estimated weights from that.
Yeah.
But I don't know how exactly they developed it.
Well, and
I know he was working on it.
I don't know how it was developed, but now, and this is actually fascinating for people listening, particularly who are sonographers. Because we do an ultrasound on a machine,
Right.
And then there's a calculation, kind of like you were mentioning, from someone who did research legit years ago, right?
Hadlock? Was that
Hadlock
one of
is
them?
one.
That was
Hill
one.
is one.
Okay.
There are tons of them that are in there.
I remember that.
And then Hadlock is the one that ACOG generally supports now.
Okay.
It will overcall growth restriction, though. That's one downside, but is it a downside?
Is that
right?
a downside?
Exactly.
To err on the side of caution?
Exactly.
That's what I talk about in fetal monitoring. Why wouldn't you want to do it when I'm concerned about the growth of my baby.
Yeah.
Err on the side of caution.
Agreed. And what's interesting is the machine could come out and say the estimated weight of the fetus is at the 80th percentile. And then when it goes from the machine to the computer, it'll be like the estimated weight of the fetus is at the 10th percentile. It's like, wait, what? Here's what happens. The ultrasound machine is set to Hill or Miller or one of the type of calculations,
Right.
which may be from 1975, 1982. There, you can choose like 50 different options. Are you using femur length, humerus length, abdominal circumference, and head
Okay.
circumference? Only 3, only 2. You see what I mean? So whatever
Sure.
this one's set to may not be what the computer itself is set to. So you'll have a discrepancy.
Could it be that wide of a discrepancy?
Yeah. It is
That's
the
a little-
weirdest thing.
That's a little frightening.
It is, but think about like if you had data from the 70s and now we have data from 2018, hopefully our data from 18 is inclusive of what we learned in the past.
Right.
So I encourage anyone listening who's a provider or a sonographer, double check that.
Check your data.
Check your data because you'll see different things. And this is one of those things where if you don't know it's there to look at, you're never going to realize that's a problem. And if they change it in your system, you might have a baby that's normally grown and all of a sudden looks growth restricted,
Wow.
but it could have been that way the whole time and you missed it because you weren't using the right, appropriate, recommended calculation for the weight.
Again, truth stranger than fiction.
Exactly.
That should be like the theme of our
So
talk.
I like it. I like that quote. That's good. All right, let's see. Question number 8. What makes up amniotic fluid?
Fluid from kidneys.
Yep.
So urine.
Yep.
And from lungs. And
Yep.
it's primarily water.
Yeah.
Mostly H2O.
Yeah. I think people forget that sometimes.
Jeez, this is tough.
I
These are
know.
tough questions.
Well,
I'm like,
but like it's they're kind of tough, and I'm like, you know what though, we can figure this out. This
oh
is, you know,
yeah,
right?
absolutely. Not my typical questions.
no,
though.
I know.
Like it. I like it.
I
It's like
know.
a challenge, and I didn't know about any of them.
See,
So.
well, and when my sister had a kid, and when my friends have kids, I think that they sometimes feel like they're supposed to know all this. I'm like, no,
Oh no,
you're not. I mean, like,
No,
ask or
trust
like,
me.
but these are the things that like. All the free stuff, guys. Free downloads on the website. It's where you get this
Absolutely.
stuff. If you want to know, if you don't, hey, ignorance is bliss sometimes. Go for that too. Question number 9. Who should be offered Down syndrome screening in pregnancy?
Oh, that's a good question.
It's a great question. I think it's a great question. Thank you. I'm glad you think it's a great question too.
Well, when I was in practice, which now has been many years because I've been teaching fetal monitoring, we definitely offered anyone who had a family history, and we offered women 35 or older.
Yeah.
But now I'm wondering, is it everyone?
It is everyone.
See, that's what I thought.
And there's data. I want to say that one of my friends that does sonography, that's a sonographer, when something changes in recommendations, wouldn't you say it takes about 15 years for that change to truly kind of become standard?
They're saying 15 to 17 years. And
Great.
from something to be published in the academic literature, that's
Sure.
a change in standard, to actually trickle down to clinical practice, which is, why we need more classes and our professional organizations need
Agreed.
to do more
Agreed.
to kind of get the word out sooner.
Yeah. And that's what one of my big pushes is for this. I did a video on what is Down syndrome screening and then what is a soft marker, because oftentimes people are like, well, I don't need to do Down syndrome screening. I don't have a family history, right? Because that used to kind of be the mindset of it. But we know that most Down syndrome is sporadic and random and
Unrelated.
not
Unrelated.
considered to be in the family. Yeah. So, all right. Kind of like I always relate it to breast cancer because people are like, well, I don't have to have a mammogram. I don't have breast cancer in the
Oh,
family.
no.
No.
No,
No,
I
no.
don't care.
Squish the boobs.
Give me the mammogram.
Yeah, I know. Question number 10. This is our last question here. What is carrier screening?
Carrier screening is to check the parents to look for genetic markers that they might carry that when combined from both parents could create problems.
Yeah. And this is the thing, too, that I think people forget that should be offered to every
Absolutely.
patient. Should be. You don't have to do it, but you should be offered carrier screening to know if you carry something, because then your partner can be tested. And then y'all can find out if you have a risk of having an affected child. Cystic fibrosis is the one that always stands out in my mind. And when someone tells me they had a surprise cystic fibrosis baby, my first question is, did you get carrier screening? And they're like, no one offered it to me.
Right.
And that makes me upset.
Well, and it is upsetting in that I think one of the problems we have is we don't have consistent, standardized kind of approaches. So that it depends on who I'm going to,
Right.
what kind of care I'm going to get.
Well, and here's pet peeve, side note, tangent here. We have like governing bodies. We have the American College of Obstetricians and Gynecologists.
Yes,
That's
we
a
do.
big one that
Right.
I would say that's a good place to say is our go-to spot in OBGYN. Yeah.
I
One
think
of 'em.
it's one of them.
One of 'em.
I'm really leaning toward a lot of the SMFM, Society
Yeah.
for Maternal-Fetal Medicine.
Yes.
Because I think they're working more often now in conjunction with ACOG.
Yes.
And really getting out best evidence
Yes.
and latest
Agreed.
research. So both of them.
Yes.
Yeah, absolutely.
So we have two.
Yeah.
Because, ACOG is above gynecology as well. So, and
Right.
then SMFM is really obstetrical
Strict,
stuff. So
right.
I like SMFM too. They're my jam. Shout out SMFM.
Yes.
My thing is though, if we know we have that's there, how can you have an excuse as a provider, physician, where you're like, oh, I just had no idea? Do you know what I mean?
Because a lot of people are not involved in their professional organizations. One of the things that I tell all the people that come to my classes is be a member of your professional organization. Whether that's the American College of Nurse Midwives, whether that's AWON, which is the Association for Women's Health Obstetric Neonatal Nurses, or ACOG, College of OB-GYN, or SMFM. But be a member of your professional organization.
Yeah.
And even if you're not super active, like you're not running for office, you're not doing stuff, you can get those materials and review them. So a lot of help. There's a lot of help available, but you have to avail yourself of it. And I really think you have to make time for it. Because if you're a physician or a midwife or even a nurse, you're in a busy practice, you're working, it's tough. It can be tough to make time. So I don't understand why hospitals aren't doing more of providing education, or departments like the nursing department, the OB-GYN department, providing new information.
So we are going to end today with 10 true false questions.
Okay.
And
I'm so
they'll
excited.
be fast. All right. Okay. Question number
Are
one.
they right or wrong? Is
True
there
or
a right
false?
or wrong?
It's just either true or false.
Okay.
Well, and if you're like,
I don't know.
Lexi.
All right. I'm scared.
No.
All right.
Okay. Number one, a fetus can have hair in the womb.
Yes.
True or false?
Oh, sorry.
Oh my gosh.
True.
Yes. That's what someone else
True,
said.
sorry.
They kept saying like yes. I'm like, no, it's true or false.
True.
Okay. Question number two, true or false? A pregnant patient's heart rate will increase during their pregnancy, like the patient themselves.
True.
True. Correct. Question number three, itchy palms during pregnancy may be a sign of a serious condition during pregnancy.
True, but I can't remember what it is.
Cholestasis of pregnancy.
That's right.
Or intrahepatic cholestasis.
Thank you.
Question number four, everyone should be screened for diabetes when pregnant.
True. I almost said yes.
Close. Question number five, everyone should be screened for thyroid disorder when pregnant.
True.
False.
Sorry.
That's
I
okay.
thought, why not?
They do it though. They're not supposed to,
All
but
right.
that's okay. Question number six, someone with 2 prior cesareans has to have a 3rd cesarean.
False.
Very good. Question number 7, twins that are the same gender are always considered identical.
False.
Correct. Question number 8, no cheese is safe to eat while pregnant.
I'm going to say false.
Correct. You can eat some cheese. It's
I
just,
was like, don't take my cheese
Don't take my cheese away. Question number 9, someone trying to get pregnant should start taking folic acid before becoming pregnant.
True.
Question number 10, baby aspirin is an over-the-counter medication that can prevent a certain type of high blood pressure during pregnancy.
I don't know, because I think there was different data on it, so I can't remember.
True.
Okay.
And we're we're at this 81
Was there
milligram.
not conflicting data on it? No.
The question has been the amount right now because it's 81 milligrams. Because they looked at aspirin, they looked at calcium, and the calcium was like They looked at a couple other things, but the aspirin did decrease the risk of preeclampsia in certain people. Right.
Okay.
So it's not like we give it to everyone, but if you have enough risk factors,
so it's specific.
Yeah,
All right, then
it's specific.
I don't feel too bad.
Don't feel too bad.
All right.
And now they're coming out and saying some of the European studies to take. We don't have the amounts they use in Europe.
Right.
Right. So we're like, oh, well, we'll just give them 2 of the 81 milligrams. I'm like, is that correct? And there is a recent study in certain individuals that may be better at preventing preeclampsia, but still the across the board is 81 milligrams. So just the teeny tiny baby aspirin.
That's why God made maternal-fetal medicine
right.
specialists, because I just teach fetal monitoring.
And I have to say, that day that I was on in front of hundreds of people and getting asked questions, I was like, oh my gosh, this is like, I don't want to say the word hard, but it was hard to get exact numbers, exact information about fetal heart rate monitoring. Like
right.
You show me a strip, I can talk to you about it and I understand it and all that. Like it's the difference in like being comfortable with like, yeah, I know that. And like really in detail describing it, which is an important thing to be able to do. And that's why I loved your course, because I was like, ooh, I got learned.
Thank you.
I got learned.
It's specific, but it was great.
It was great.
Because you wouldn't have that. My expectation was not that you would know that inherently, because you're not using it all the time and you haven't been to classes on it. But the idea that the only people that need training in fetal monitoring are labor and delivery nurses, that's crazy.
False. That's false.
False. Yeah, it would be false.
And I love, this is what I, in my opinion, part of what brought us together as friends and colleagues, clearly colleagues in a way, is that I get frustrated when physicians, or even anyone that's in the nursing field, that they're like, we're over here and you're over there and we are not together working for patients. That's horse shit. It bothers me.
Totally.
And it's like we're all working to help patients. There should not be a hierarchy in this. And I want to learn from you. I want you to learn from me. I want to work together all the time.
We are going to be working together. Yay.
Get ready, people.
Yeah.
It's going to happen.
It's going to be Lexi and Lisa take over the world.
Like Beavis and Butthead, but a little
better.
bit, but better.
And
but
better dressed and better hair.
Dressed and better voices. Theirs is pretty
better
like
voices.
it's
Although my Chicago nasal hair,
I love it already.